March. Yes, thank you, Durandi. Welcome to our March Cost Growth Target Technical Advisory Group meeting. This is a monthly meeting. It's completely voluntary for payers, provider organizations, and various partners interested in the Cost Growth Target program. Hold on, let me see here. Okay, thank you. All right, so let's go ahead and get started. Next slide, please. Okay, so our March meeting, we are, this is the agenda breakdown. We're going to continue a topic we started last month in February. That's agenda topic number 4. So this is entity level public reporting. The report we are publishing later this spring is going to include entity level trend numbers for the first time for all payers and provider organizations that meet the size threshold. So we'll continue that conversation. We had great feedback last month and requests to throw up some mock data viz with actual names so it could feel a little bit more real to people. So we've done that and we're excited to continue the discussion this month. The other topic we'll talk about are the updates to the 2023 data submission materials. That's agenda topic number 5. We're going to go through some of those revisions. Nothing substantial changed, but we do want to cover those with folks here. One of the tag attachments to this meeting is the draft manual. So you can see where those edits are in the manual itself. And of course, you'll have the whole rest of March and most of April to review the manual. And in our April tag meeting, that's where we'll go into more detail about those changes. And that's it. That's our agenda for today. Next slide. Okay. So this is just a summary slide of our February tag meeting. This is where we started talking about entity level public reporting for our cost growth target report. In that meeting, we reviewed some examples from 3 other states that are a little bit ahead of us in terms of reporting. So we looked at what Rhode Island, Delaware, and Massachusetts chose to do. Each state does it a little differently, and we went over some of those differences. Some states have confidence intervals to display. We are one of those states. We are actually the state that initiated that methodology. Have to put that plug in. We looked at how these states arranged their organizations by market. We looked at how they displayed member month size. Not everybody does this. Maybe it's not very useful in the report, but we started discussing that. And we got a lot of great feedback and are continuing that discussion with you all today. And then the other topic we discussed was the list of provider organizations for that 2022 cycle of data. Next slide. All right, let's get into some program updates. Next slide, please. The accountability update. So we've broadcast this news to, I know, this group and to various folks whenever we make contact with you, I feel, in emails and in data validation meetings. So you're probably sick of hearing about this, but we wanted to publicize this again in this meeting. And that is the accountability timeline has shifted. So some of you may already know, PIP's performance improvement plans have been delayed by 1 year. So if you look at that second to last row, do PIPs apply? You'll see that they are not in play until 2024. So data submitted in fall of 2024, which covers spending from 2022 to 2023. That is the cycle where PIPs will come into play. So all these data validation meetings we've been having with folks where we look at the trend, see something of interest, we burrow down in your data output to look at the categories and talk about like what's a major contributor to the trend. We're going to be doing that conversation with you every single year. But particularly starting in that year, we'll want to be more detailed and explicit about these reasons for cost growth if you are over the cost growth target.
And Karen, can I add a quick clarification here? I think with the revised accountability timeline, that cost growth target year 3, data submitted in 2024, report published in 2025, that is the soonest possible time that an entity, a payer or provider organization could be put on a performance improvement target. I just want to recognize and state for the record that of course things are still happening in 2022, 2023. Things are still maybe a little unstable. We might be seeing that reflected in the data. It is very possible that we don't put anybody on performance improvement plan in that time period. So it's not an automatic this applies. That's just the soonest that it could possibly happen. Not that it will definitively happen.
Yeah, that's a great call out. We're going to be discussing these macro trends for maybe a while. So we wanted to publicize this timeline again. If you look at those 2 links, the first is a 2-pager accountability update. It talks about this revised timeline and also talks about the plan for rulemaking later this year. I think that's the next slide. And then the second link is a facts document for provider organizations where accountability timelines, due dates have also been updated. Next slide. I think this is the rulemaking slide. Yes, okay. So with that in mind, we are still going to stick to our rulemaking schedule for this year. This is an overview snapshot of what that looks like. So with you all, with our technical advisory group, we are planning on sharing the draft PIP templates, other guidance materials, as well as the financial penalty options to you all in the June, July TAG meetings to gather feedbacks, thoughts, comments. And then later in the summer, July, August, we're going to launch our Rules Advisory Committee recruitment and hold the Rules Advisory Committee meeting itself in September. We're luckily not too constrained on the timeline here because PIPs have been delayed. So you can see the later half of this timeline is just TBD. That's for bulletin posting, hosting that public comment period, the public hearing, and then finally posting that permanent rule filing. So that may go into early 2024, and that's okay. When it comes to the RAC recruitment, we will definitely talk about it in this meeting and send out emails to our TAG members. So you all are aware we're doing that recruitment and you can apply to be a member of that committee if you wish.
Trang, I want to add a couple of notes here. When we did the data submission rulemaking for the cost growth target program, we repurposed the TAG meeting as the RAC. And I want to be clear that for the accountability rulemaking, we are not going to do that. So we'll talk about some draft documents. We'll probably share the draft rules, but we will hold the official RAC recruitment, RAC process, all of that separately. So there will be that recruitment. We will be inviting payers, providers, other interested stakeholders to apply to be part of the Rules Advisory Committee. And all of that will be in addition. So you, as Trang said, you'll be notified, but just wanted to clarify that it will be a separate meeting, which is not how we did the data submission rulemaking. I also want to say that you might be wondering, why are we doing accountability rulemaking now? Why are we starting it this summer if we've delayed accountability rulemaking, if we've delayed accountability and the PIPs by 1 year, as Trang just covered? And I think this is a little bit of a balancing act for us, where you all have a lot of questions. We've had a lot of conversations with you about what does it mean to be put on a PIP? We don't have clarity about what this could look like, and there's a lot of uncertainty here. And so even though they would not apply until that delayed timeline, we think there's some real value in continuing to develop this out and doing the rulemaking now, so that entities have a better sense of what could happen, what's to come, and that we have more lead time for development if we need it. So I think there's a little bit of, like I said, tension here between we're planning to do accountability rulemaking this year, even though it doesn't apply for a little while longer, but we think it'll be beneficial to just be able to provide that clarity to payers and providers and other interested parties about what this all actually looks like, and have that locked down well in advance before it rolls out. Should we pause for questions or comments here, Trang?
Yeah, I was just gonna say, ask if anyone had questions. All right, I think that was a pretty lengthy pause. I think we can go on. Next slide, please. Okay, Sarah, this is you.
All right, so just a recap of our March 15th Cost Growth Target Advisory Committee meeting. The committee met in March. There were 3 major topics on the agenda. The first was reviewing some top-line trends from our upcoming 2018 to 2020 report. So this data will only be published at the state and market level, not identified payer or provider level yet. And one thing that was a little different here was this was the first time that we've actually talked about data with the advisory committee before we publish the report. Usually we publish the report and then have a conversation with them about it. So they had some really great feedback and suggestions, one of which a couple of which we're going to talk about in a minute, but there is some new data, preliminary data in the March materials if folks want to see that. The advisory committee also continued their discussion about pharmacy strategies and how to address some options for pharmacy cost containment. And then they spent the second half of the meeting talking about the upcoming 2023 report and public hearing planning. So this is the report and public hearing where payer and provider level performance will be identified. And we wanted to get some direction on how best to handle some of this. Next slide. One thing that the advisory committee asked us to do, so we wanted to give you a preview today, is to make sure that each payer and provider organization that will be identified in the upcoming report has an opportunity to see their cost trend as it will be published. So I know that we talked in this meeting last month, we'll talk more today about what the data visualization looks like. We've had individual meetings, or we've sent you your data output and you've seen your own data points or data points, depending on the markets, that will be in the report, but you haven't seen that in context. You haven't seen that relative to other entities. You haven't seen that relative to the state average. So what we are going to do in the next, I don't know, week, 2 weeks, sometime soon, is send all of you an individual email with your specific cost growth trend value for any markets that you would be reported on in this upcoming report. As well as the range, a high and low, for your own group. And we'll talk more about what groups mean, but essentially payers, by market, and then providers were doing some grouping. So all the pediatric practices would be in a group together. We'll show the low and the high range, your own performance within that range, and then the state average for each market. So the table on the slide here is just an example of what that could look like. So we really want to provide you some more information and give you a better sense of where you are relative to the group, and also be really sensitive to not releasing identified data in a bunch of different ways prior to the public report. So this will be coming. We'll be happy to talk with you all about any questions or concerns you have about what's in this quick summary, but the advisory committee was really concerned that everyone would have a chance to understand their own performance relative to everything else before publication. So we'll be pushing this out soon, and this is a new piece of communication. We were not planning on doing this until the advisory committee requested that we do this last week. Any questions or comments about that? Bill?
Yeah, I was just wondering, when you're saying there that you're going to provide the state average, I'm just trying to understand a little bit more about what that average would mean. Like, for example, you could do a simple average of all of the different providers, but maybe you have a situation where some large providers have a certain rate and some small providers maybe have consistently a different rate.
Oh, are you? Yes. So it's not, it's the state average, sort of I was originally thinking that was the whole market average. So all commercial payers or all commercial attributed lives. But I think what you're saying is that it might actually be more helpful to have the group average. So the group low and high and the group average, not the state average. Is that a fair leap of assumptions to make?
Well, no, I was just meaning like is it a weighted average in some way, or is a a payer or a provider with 200 members weighted equally to someone with 2,000 members?
It's not an average of the organization performance. It's all of the lives statewide in that market. So, I mean, yes, it's weighted in that organizations with more lives are in there, but it's not an average of the individual organization trends. It's the state total, if that makes sense.
Okay.
What I'm hearing is we should provide some definitions in this cover email.
Sounds great.
Okay. All right, let's go to the next slide. The other piece of the advisory committee's conversation that is a change and that we want to share with you as soon as possible is about the public hearing. So we are planning on doing our first public hearing that will talk about payer and provider organization performance relative to the target this year. We were originally planning to do that in May. Our staff proposal was to repurpose the May 17th cost growth target advisory committee meeting to be the public hearing. The advisory committee agreed with that. And also they said we should split the public hearing into two parts. So we're going to do part one in May on the 17th and part two in September, and we need to figure out the date for that. So the part one will be a virtual meeting, and it will be focusing on context setting. So sharing the report, presenting on the data, talking about some of the state level, market level trends, talking about challenges, talking about impacts on consumers, really foundational context setting. Part two will be informed by that May 17th context and all the information sharing, but that is the part of the public hearing process where there will be an opportunity to hear from payers, provider organizations, other stakeholders about what they're doing. So both now and in the future to contain costs. So as we've been talking about public hearing planning, we've been saying, okay, do we have panels of payers and provider organizations? Does the Cost Growth Target Advisory Committee want to invite certain payers and provider organizations that they want to hear from? All of that component of the public hearing will be happening in September. So we are going to be working on the agendas for both of these meetings, pinning down the dates, getting out a save the date, probably in April. So more to come on all of that, but just wanting to keep you posted on how this is evolving. Questions or comments about the plan for the public hearing? Okay, none. Let's keep going. Also, just wanted to share with folks, the Cost Growth Target Advisory Committee has launched a short-term work group focusing on cost and equity. So their charge is to focus and refine equity approaches for cost containment efforts. And they'll be making a recommendation back to the advisory committee in September. So the work group held their first meeting at the end of February, and their second meeting will be next week. So just letting you know about that upcoming meeting. The meeting will be public, and the link is on the committee webpage for all the meeting information if anyone is interested in listening in. Next. And then I think our final program update for today is just where we are on the 2023 legislative session. So as we've shared before, there were 3 bills that were introduced in the House Healthcare Committee that would modify or alter the cost growth target program in some way. We recently had our first chamber deadline where bills needed to be scheduled for a work session to be sort of alive and still moving. And of those 3 bills, House Bill 2742 has been scheduled for a work session on April 3rd. So 2 of these 3 bills have had a public hearing, and one of these bills, 2742, is scheduled for a work session and potentially still moving forward. That is my legislative updates. I think I don't have any more information than that other than what would be available on OLIS. Questions about any of that? Okay, you're all quiet today. It's making me nervous, but I hope that the next agenda item gets us a little more discussion. Next slide. I think I'm going to keep going, right? Okay. All right. So as Trang said, we are going to have some follow-up from our February meeting and continue our conversation about how to do the public reporting at the payer and provider identified level. Next slide. Okay, so I'm going to recap some information that we shared in February just to make sure we're all on the same page. So this report will be released in the spring. We're aiming for late April, early May. We're measuring healthcare spending between 2020 and 2021. We're using the 2022 data submission files. We're reporting it at the state level, the market level, and for the first time, identified payer and provider organization. Next slide. This is a summary of the anticipated number of payer and provider organizations that will be reported on. So based on enrolled members and attributed lives by market, not all payers and providers will be reported on in each market. So we have 29 payers that will potentially be reported on and 51 provider organizations, but that really breaks down once you look by market. So we will report the most number of payer and provider organizations for Medicaid, then Medicare, and then finally commercial on the payer side. Next slide. Okay. In February, we talked about how other states were doing this. I'm going to summarize our takeaways, sort of the decisions or the consensus from the group that we heard. So generally, you told us that we should report and list the entities alphabetically. That makes sense. Payers and providers will be listed alphabetically. That we should add a state average to the visualizations so that there's also that reference point, and that we should differentiate provider organizations. So this is more about that group reporting. We should report all the pediatric practices together. We should report the FQHCs together, the larger health systems together, and that those would all be on separate graphs, presenting that data together so that we're not putting, say, a smaller FQHC next to a large health system and saying that their cost growth is comparable. So yes, we are going to do all of those things. We had some mixed feedback, maybe not a decisive agreement on whether or not we should incorporate the entity size into the graph itself. So we shared some examples, mostly from Massachusetts, about how they were doing that, using larger bubbles to represent larger payers and providers. And we weren't sure if that was a good idea or not. We also weren't sure, we didn't have consensus on whether or not we should differentiate or somehow indicate payers who are domestic payers, so operating in Oregon, Oregon-based, versus those who are the larger national payers. There was a request at the end of the February conversation to see some Oregon-specific mock-ups with the entity names by these groupings actually listed out. So that's what we're going to talk about today. And I think part of what's going to help us here is that we didn't have a good sense of how many organizations would be in each group. And so it was a little hard to say, like, will this visualization work? We don't really know how many entities we're talking about. So are there 40 entities on a single graph? That might be too many. That might influence how we want to present the information. So what we are going to do today is show you the groupings that we're proposing, and we have some questions for additional feedback. I don't think we really want to revisit the alphabetical question. If anyone has real concerns about that, let us know, but I think we're going to keep moving forward on some of these questions that we haven't landed on yet. Okay, next slide. Also, just a reminder, our proposed visualization is in the graph on the left. So organizations would be listed alphabetically. We would be doing horizontal bars. The cost growth target is the line here in orange. You'd see each organization's cost growth value would be the blue dot with the confidence interval bars in gray. We will also have a lot of context and narrative and tables that summarize the data and a met, not met, or indeterminate status, but this is sort of the high level snapshot of the visualization. Also the slide just summarizing the decisions and where we are. So we'll report by market, we'll show the confidence intervals, maybe we'll show relative size, that one's still TBD. We'll report alphabetically, we'll have a table with met and not met. We will differentiate the provider organizations into those groups. We will not report by payer and provider. So one of the examples that we talked about in Massachusetts was they actually broke down some of their large provider organization performance by payer. So essentially saying for this health system, their 3 dominant payers who attributed lives were this, and here's the cost growth specifically at that sort of cross-tabbed approach. I think we are not going to do that for this report. We might come back to that in the future. Certainly that's something we've been talking to you all about in individual data visualization or individual data review meetings. And we might come back to that for a future report, but not for this first year. Okay, next. All right, I cannot say this enough. All of the data that you are about to see is made up. Everything on these slides is fake. So please do not try to take any conclusions from anything you're going to see today. These numbers were pulled out of a hat, and I just cannot say enough that this is fake data. So real organization names, fake data. So today, what we're really hoping for some feedback on is, I think mostly the groupings, and then coming back to that relative size. So let me start walking you through the fake data. Okay, next slide, and one more. Okay, so this screen is small on purpose, because again, this is not about looking at the data and the values. This is just getting a sense of how many we have in each group. So these are the number of payers that we expect to have in the report by market. So you can see we have the fewest number of payers in the commercial market, and then increasing until we have all 16 Medicaid coordinated care organizations. They are listed alphabetically, so this is the order that they would be listed on in the report. And again, the data are fake. So I'm going to pause here for a second because I know this is potentially a lot to take in. Are there any immediate questions, reactions? I feel like this is actually a much more straightforward conversation at the payer level, because we're not doing any other groupings other than by market. Does this make sense? Is this roughly what you expect to see? Does this horizontal bar graph still make sense given the number of payers that we see in each market? Got a thumbs up from one payer, thank you. Comments in the chat from another, great, excellent. Okay, I'm gonna assume that there are no concerns. This seems very straightforward. Thank you for agreeing with me on that. The one question we have for payers is, should we indicate whether or not payers are operating nationally? We could do that with an asterisk. We could do that with a different color, although that might be a little confusing. We could just have some narrative that describes, and when I say, domestic versus national, I'm talking about, I'm going to pick on All Care. So All Care operates in Oregon as opposed to Aetna, which operates nationally. Drew, I see your hand.
Thanks, Sarah. What would be the purpose of indicating whether a payer is like calling out specially that a payer operates nationally? And even how do you define national with, like, if a payer operates in Oregon and Washington?
Great question.
And say Utah, is that national? I first more, I just want to know what's the point of saying this payer is national versus not national?
Yeah, I can editorialize a little bit, and then I might open up for some other perspectives. I think we've seen other states do this, and I think the reason behind that is some assumptions about leverage and ability to control costs. There might be some assumptions made about larger national payers might have more opportunity to negotiate with providers, or they might have more power in some of those negotiations. And so their ability to control costs might look different than an organization that only operates, or a payer that only operates in state. This might not be a relevant argument for Oregon. I think if you think about, and I'm going to pick on names here, so sorry, national folks, but if you think about United, there are some states where United has almost all of the commercial market. That's not true in Oregon. They have a lot smaller of the share compared to some of the other payers. So I think there could be some assumptions that national payers are more dominant, and that may or may not be the case. I think one thing that might be interesting, relevant, is to share membership in Oregon, and just have that as part of the report for some additional context. So how large is each of the markets, or how much of the market share does each payer have? And that might be more relevant for this report and for providing context than whether or not they operate in any other states other than Oregon. My team, does anyone have any other thoughts or comments on this?
I was just gonna add to the, how do you designate foreign versus domestic insurer? And it's how it's from those DCBS quarterly health insurance enrollment files. They have payer attribute fields.
I see some additional comments in the chat about maybe, not sure if this is relevant, or not sure if this tells us anything. I think, given this sort of lack of enthusiasm here, my preference would be that we do something around market share or enrollment instead, and just have that for context. And we're also talking about doing something on the provider side that would show attributed lives size. Oh, and we've got another comment in the chat about what about nonprofit versus for-profit? I think that is an interesting question. I don't know. What do folks think? Would that be of interest? And B Corps. Yep. Are B Corps technically nonprofits? Like, which way does the Venn diagram work? All B Corps are nonprofits, but not all nonprofits are B Corps? Or are they totally different?
I'm just going to go off of mute.
Yeah, thanks, Ada.
B Corps are for profit, but they earmark enough things in like a nonprofit type perspective, giving back to the community to get that certification. So they're for profit, but they're not just for the most profit.
Got it. Okay. I see Drew's comment in the chat that national indicator or profit status may not be relevant. Thanks. All right. Add complexity and noise rather than value. Agreed. Okay. I think tentative conclusion of this conversation, let's not add national versus regional indicator. Let's not explore for-profit, nonprofit, B Corp at this time. We might come back to that later, but not as something that we incorporate in these graphs. And that we will pursue including either market share or enrollment in some way in the report, not in these graphs, not that adds too much information, but elsewhere in the report we'll include some information about that. Okay, payers, any other comments before we switch to provider visualization? Yeah. Okay, great. Thank you for that feedback. All right, let's move on to the next slide. Okay, so we're going to switch gears to talk about provider organizations. So we have 3 proposed groupings. They are health systems and group practices, pediatric practices, and federally qualified health centers. This can be broad strokes, especially that first group. And my first question for you is, do we need to split that first group up? So let's look at the mock-ups and then we can talk about that. And then for each group, we would have a graph for each market. So commercial, Medicare, Advantage, and Medicaid. Next slide. So this is the largest group. So this is health systems and group practices by market. You can see we have a lot more entities on these graphs than we did on the payer graph. Commercial, Medicare Advantage, and Medicaid. Again, this is exactly the same visualization. Organizations are alphabetical. We've got the confidence intervals on the horizontal bars. Question, is this too much? Are there too many organizations here? Should we look at splitting this grouping up into a smaller group? And do we want to separate out health systems from group practices? Is it not fair, not an apples to apples comparison to have them on the same graph? Drew.
Thanks again, Sarah. I'm not 100% sure about the distinction between health systems and group practices. I think it's kind of like an adjacent to perhaps just overall size. And so maybe there is a size segmentation.
Oh, interesting.
Worth approaching, as opposed to like organization. Are you an integrated system or not an integrated system, which I think is kind of what you're getting at. But actually, more importantly, in terms of segmentation, I think there might be an aspect of geography that is relevant here. That isn't reflected here. And I know, like, we have every geography has the same target, but there are every geographies might reflect unique issues.
Yeah, okay, so there was a lot in that comment. Thank you, Drew. I think I really like the idea of a size threshold. So we could have health systems and group practices above and below a certain cut point of attributed lives. So that makes sense to me. I think we'd want to go back and look at the data and see if there's a clean break, sort of a logical separation, but I really like that as an approach. So we'll poke at that a little bit. If anyone has really strong concerns about us doing the size separation, let us know. The geography piece is a lot more complicated. I think our team really, really wants to report by geography, and we want to figure out how to get there. And also, because of how we report at the provider organization level, we roll everything up to the parent organization. So to think about Providence as a provider, there are multiple Providence facilities in the Portland metro area. There's also Providence facilities in Southern Oregon, but we're reporting all of those together as Providence. So if we're thinking about a regional grouping, where would we put you? So that it gets complicated really fast because of the parent organization roll up. If we were reporting at the facility level, then absolutely that's a no-brainer, but we're not. And many of these organizations have facilities across the state. What do you have suggestions on how to solve that? Yeah, it's tricky. I think there might be some clustering that, maybe, but at that point it starts feeling like we're picking on organizations that have fewer locations, because then they're easier to geographically cluster. Bill, can you maybe come off mute and talk about your last comment? I'm not sure I'm fully following.
Yeah, I'm just saying, so my understanding is the way you're doing this is the definition of what the provider is you're saying that it is members attributed to the PCPs at this organization. So
Yes,
for example, you wouldn't have, Compass Oncology showing up in there because they're a specialty group. So they're not even going to be included in this.
Yep.
And so, I mean, we know that primary care is a tiny fraction of overall medical cost. And, you might have maybe one of the things you're thinking about when you're thinking about geography is, what if there's a primary care group that is dependent on a certain hospital if it's the only game in town, and if that hospital raises their prices, there's nothing that the primary care group is going to be able to do about that. They could be the most efficient primary care group in the state, but their cost is going to look bad because of things that are not under their control. And so there's tools that will allow you to see, based on the member's risk, how many services in general are they utilizing? So you could see differences in, how often do they refer somebody out to a specialty group, or how often do they take care of the problem themselves?
yeah. Okay, great points. Yes, and I think we absolutely want to be pulling all of that information together as part of this program and exploring what are the cost growth drivers and where are the opportunities. So it's not necessarily an immediate breakdown of this data, but it is part of the rest of the reporting and analysis that we're doing and that we're working with a number of you all to do as well. So yes, but I don't think it's something that we necessarily are going to add like as a direct stratification of this graph, for example. Fair?
Yeah.
Okay.
This seems like an appropriate time since I'm off mute. I mean, one of the concerns I had with just how you guys are doing this is just the idea that we're reporting standard deviation, and you could have two groups. Say there's a PCP group with 2,000 members and one with 500 members, and for each one of those, they could each have 1% of their members being super sick and have a lot of different costs. And both of those provider groups would show the exact same standard deviation. But clearly the one that has more members, the data is going to be more reliable because they've got 4 times as many members. And so,
Yeah.
so it seems to me, and I don't know how you're doing it, but it just seems to me that that you would have to take into account how many members they are in your
Yes.
calculation.
Let me add. Yep.
reliability.
I think I know where you're going. Let me add 2 clarifications. And this, again, we've been working on this and there are a lot of details that have sort of been layered as the decisions are made and the program is built. So one is that we have a threshold. So every provider organization that we're talking about at that parent organization level must have at least a certain number of attributed lives. So in the data itself, the data that we're receiving from payers, we have many hundreds more provider organizations that are below the threshold for reporting. So there is a cut point that, and team, don't let me get this wrong, it's at least 60,000 attributed. Yeah, at least 60,000 attributed member months in both years of the measurement period. So
Okay.
any organization that has fewer than that is dropped off the list and not included in public reporting. In a market, yeah. So it's not even in total, it's at least 60,000 member months in Medicare Advantage before you even make this. So I think we're really trying to control for that small number, small variation. And there are a lot of organizations that fall below that threshold. And on one hand, I think we're trying to be really like fair and balanced and present data as accurately as possible and take those small numbers into account. And also, that's a lot of the health system that we're not necessarily seeing because they're below the threshold. Greg.
Yeah, and that's exactly the point I'm getting at is let's say you take Kaiser and you go through and you say, well, that's a big provider. So we're going to go ahead and put them out there. But then we're going to do this geo thing and we're going to sit there and find some small town clear back in nowhere of Oregon with only 3 people. And we're going to report that trend. Yeah, and I'm taking extreme examples. Well, you're not going to go through and redo their confidence interval to give people a feeling as to how much volatility. So when you start looking into some of this geo stuff, my concern would be, do you take somebody who across the state has some measure of confidence interval, but the minute you bust them up into different areas,
yep,
now you've created numbers that it gives the appearance that there's confidence in that number, because let's say you had a very tight confidence interval, but it's not meaningful because now you've lost the credibility associated with trying to break it into geo. So that would be my only concern about trying to take a provider and split them up across the whole state, is because of that confidence level.
Yeah, I 100%. That is part of, I mean, that this is all the conversations. It feels like today is a culmination of the last 2 years of discussions around this, where, yeah, we had a lot of discussion about, do we roll everything up to that parent organization, sort of the highest level, or do we try to do facility level reporting? And attribution at the facility level is a whole different conversation. And yeah, I don't think that we want to split organizations up like that, because then we run into our size threshold. Where I think there's the most opportunity is, you know, thinking about how this report feeds into ongoing conversations and feeds into the public hearing and the panels that we'll have in September. Like, I think there are going to be really good questions for payers and provider organizations where we say, okay, Kaiser, it looks like your Medicaid cost growth was this, like, what's going on? And that's when you would come and say, well, you know, we did some analysis internally, we've really thought about this, and it looks like what's happening is this small town in Oregon with 3 people. That's a bad example, but I think part of that is where we want to have that as more of a conversation starter, rather than something we're going to definitively be able to categorize and say for every region in Oregon or for every individual facility, because you get into so many methodological issues with the attribution and with the small numbers that I just don't think that that's going to serve our needs. And so this is the level of reporting we want to do, but it's to support that broader conversation and that drill down conversation with information that all of you will be able to provide. Because I think you are all in the positions, and maybe not you personally, but, you know, your organizations are the ones having these negotiations and knowing, oh, we only have one hospital in town, we have to contract with them, their prices went up. We have to refer our patients there, their prices went up. Those are the kinds of pieces of context that you'll be able to bring to the broader discussion. Okay, I want to bring us back to sort of decision-making around this. I think, to summarize what I heard, geographic would be cool, but we're not going to do it this time. We might continue conversations about that. If anyone has really brilliant ideas about how to solve that, like, let's talk, but not for this report. For this report, rather than trying to split up health systems and group practices into 2 separate groups, maybe we keep them together, but we look at a size threshold, and our team will look at the data and see if there's a natural break point in the data. Make sense? Any issues with the size threshold cut to split these into smaller graphs? Okay, cool. Next slide. So that was health systems and group practices. Now let's look at pediatric practices. So here are our pediatric practices. We have 4 in the commercial market and 7, 8 on the Medicaid side. There are no Medicare Advantage pediatric practices, which for reasons that might make sense. Any questions or concerns about the pediatric practice grouping? Okay, hearing none, let's, Bill, do we exclude children from the previous chart? Nope, we do not. Children are included in all of the data if they've been attributed to any other provider organization. We just know that these are practices that primarily are pediatric. And so we're treating them we're pulling them out differently, but all of the underlying data is the same. Okay, next slide. The third group that we have are the FQHCs, Federally Qualified Health Center. And we only would have a Medicaid chart here. And we have a lot. There are a lot of FQHCs. There are a lot of Medicaid lives that have been attributed. There's a lot of attribution in the Medicaid population, probably because of Medicaid primary care home, patient-centered primary care home enrollment being in a major initiative. Most Medicaid members have a patient-centered primary care home, so the attribution is pretty clean. So we have a lot of FQHCs here, but only in the Medicaid market, not in the other 2 markets. Any reactions or questions about the FQHC grouping? Okay, let's stay here for a second. I want to ask one more question that's new. So this is a process thing, and it's very technical and boring, and I'm sorry, but I want to talk about how do we standardize the names for these reports. So there are all kinds of names for payer and provider organizations. There's sort of registered name to do business under, what you do business as, what's on your tax forms, what is in the data, sort of what's on the front door from a marketing perspective. Then there's the long name and the short name. I'm going to pick on Pacific Source here, Pacific Source Community Solution, all of that. And then you've got all the breakdowns. So Pacific Source Community Solutions, Marion Polk or Columbia Gorge. So there can be a lot. And I think we want to be sensitive to organizations, whether that's provider organizations and how they're sometimes renaming themselves, or payers have a different name for their different markets. So you might do business under a slightly different name in the commercial market than you do in the Medicare Advantage market. We know who everyone is on the back end because we have all of the data and can line it all up. But for the purposes of public reporting, do we want to simplify that? Is there a shorthand where, for the purposes of the graph, we have a short name for each payer and provider organization, and maybe there's an appendix with the full names for each market so that we could be accurate? So anyone have strong feelings about that? When we send out your individual, when we send out that table with what your cost growth will be and the range, should we say, and here's the name that we think we want to use for you in the report, and have you confirm that? Again, I want to be sensitive to the nuances here, but it gets really clunky really fast, and I'm not quite sure what the best way to handle this is. Any thoughts about how we handle standardized names? Okay, Bill says send out our best guess.
Yeah, I was gonna say we could email each group and say, what do you think about that, like Benton County versus Benton County Health Department,
Okay, we'll do our best guess, and we will ask you to let us know if we get anything wrong. And if we do end up with any, shortening or abbreviation in the graphs, we'll make sure that there's an appendix with everything fully listed out for different names for different markets or organizations if needed. Okay, cool. I think actually we've gone through everything. Let me check next slide, Gerondi. We talked about, okay, last question. Now that we've gone through that, last call, anything about incorporating member month, either enrollment or attributed lives size? I know we've talked about changing the groupings by size, but do we want to consider, larger bubbles or any other way to indicate size on the graphs themselves? I'm leaning no. I think I've heard no, but I just want to double check that. Bill, you think size would be helpful? I want to put size in the report somewhere, but I'm asking specifically, do we try to incorporate it on the graph? In report, but not on graphs, says Daniel. I think that's my recommendation that I'm confirming. No to larger bubbles. Oh, an N on the label. Okay. Possible. All right. Yes, in report somewhere. No to graph. Check. Okay, cool. And last slide for me, I think. One more. Okay, yes. So a couple things that have come up since our last conversation about this. We want to add a graphic or a table and a little bit of narrative to the report somewhere that will talk about payer partial claim percentages. So way down in the weeds of how this works, we are only reporting full claim totals, not partial claim. And there's a variation across the payers in how many of your lives and your dollars are showing up in partial claims and are therefore excluded from this. So we want to add some recognition of that and maybe a graph that shows the distribution of how many lives or how many of the dollars are in partial claims, just to to be upfront about that. Does that make sense? Any questions or concerns about including that? Okay, great. An example of a partial claim. Oh boy, Ada. I don't know if I can answer that. I think does one of the team want to take a high level stab at answering that question?
Yeah, so this is only something that applies to the commercial market. When we collect data, we collect commercial full claims and commercial partial claims. Commercial partial claims are claims for members in a plan where the payer doesn't have like full visibility. Maybe you're using a vendor for pharmacy or behavioral health, and when payers report data to us using partial claims, we direct them to estimate the partial claims. And there's flexibility in how you estimate it. You could base it off of, what you see in your full claims from those members and estimate that for your partial claims members. But when we look at the commercial market for payers and provider organizations, we're only using spending we can see from commercial full claims. And that's where the bulk of commercial claims are, but we do want to acknowledge that there are partial claims.
And this difference between the commercial and the commercial full claims and the commercial partial claims sometimes is what's popping up when we're having conversations with providers and they're saying, oh, I thought I had more lives from this payer. And it's true, you do, but from the payer perspective, those lives and those dollars are in partial claims and cannot be attributed, so we're not pulling them through. Yeah, it's not secondary payer claims. Okay, so we're gonna add a little content on that to the report. And then as I said a few minutes ago, we are going to add something to get at enrollment and attributed lives so that we're reporting on size as well, but not in bubbles. Okay, thank you all so much for the feedback. This has been really helpful for us, and I really appreciate the iterativeness and your willingness to design this with us. I think let us know if you have any other questions or concerns as you're thinking about the report. We will be following up to share your specific trend with the range and the name that we intend to report you under over email. So we'll ask for a response to those emails when they come out. And I think that is all for me. Daniel.
Thanks. I have a few notes. I'll be brief though. So related to partial claims, it would be interesting to see somewhere like what % of members insured by this carrier are included in the reporting, right? I mean,
Yep,
is that
and I think
sort of the
that's what
goal?
we're saying.
Okay,
Yep.
okay, great. And then the second thing is when you're talking about size, expressing everything as member months, like I always have to try and do the math, and it might be easier for non-math people like myself and sort of the general public if you say like average membership, or panel size or something like that. It's not quite accurate, but just a thought. And then finally, I just wanted to say, like, you've incorporated a lot of feedback and asked a lot of the right questions, and we're really thoughtful about this. And I think a lot of the quiet today is related to how well you've done that. And so I think it's clean and easy to read, and so nice job. Thanks.
Thank you for that. Really appreciate the feedback and the comments. And yeah, I hope the quiet is because you're all comfortable with this. And I know that not knowing what's going to be in the report and not knowing what exactly this report will look like, especially since it's the first time, is pretty anxiety inducing. So hopefully this helps a little bit, and let us know if you have other thoughts. We're happy to take feedback offline. So thanks. I am handing it back to Trey.
All right, it looks like we are gonna get out of here a little early. Next slide, Gerandi. So like I mentioned at the top of the meeting, next slide. I'm gonna roll through some of these updates to our, so shift your mind to the September 2023 data submission activity. So we're gonna go through some of the revisions, clarifications, namely in the data submission manual. We're not gonna really get into the weeds with these in this tag meeting, but we do want to bring it to everybody's attention, and we will talk about this more in the April tag meeting. The draft manual and I believe the submission facts document are also included as attachments to this meeting. So let's talk about some manual changes. We added a new provider taxonomy code to Appendix B. You'll see it in the manual draft. This is a new type of doctor that came on the NUCC provider taxonomy code in the middle of 2022. So not sure if folks are using it quite yet, but that is now added as a possible provider, primary care provider type. We also clarified what we mean when we say weighted average calculation for a data field in TME all. That's been updated in the manual and in the submission facts document. As you review these changes too, if something is still confusing or our clarification can use some work, please let us know. We're still in the editing stage. All right. Clarifying once again, there's no change, but just clarifying that Oregon, when we collect data for our Oregon program, these allowed amounts are not truncated. I know for payers reporting in other states do truncate their claims data. We are not doing that. Please report those amounts in full. Other clarification, this is particularly for reporting expenses in line of business 5 and 6. These are our dual eligible expenses from the Medicare side or the Medicaid side. And clarifying that these are reported on a paid amount basis, regardless of whether the payer is the primary or secondary payer for their members. Not going to get into why, but this was a long conversation last year. All right. Another clarification we're adding is the accountable markets at the payer and provider organization level, and what they align with in the data files themselves. So when you report data to us, you give us 6 lines of business. We collect dual data, we collect partial claim data, but as we discussed earlier in the meeting, when we talk about commercial market, we only talk about commercial full claims, not partial claims, but we do collect partial claims. So just clarifying a little bit for folks, you are giving us more data than entities will be accountable for. Next slide, please. All right. We have added some new facts in the submission facts document. We collect comments and questions from data submitters, payer staff every single year. Here are some new ones. That weighted average calculation is also its own question in the facts. It's the same clarification that you will see in the manual as well. The next question is it also mirrors the manual change. We're now specifying what the accountable markets are and how it lines up to those lines of business you report in the data template. The third new fact is number 21. This is how to apply the sex demographic factors. If you have a member that is not listed as male or female, we know this is a very small amount of the data. And if you have questions on how this was incorporated, you could email us, but I know we took this into account when making those demographic factor tables. They have been incorporated under the male designation. So you can use the male factor for these members if you are recording something other than male or female. And then just the last question, number 14, the way we're reporting duals on a paid basis, payers, if you are covering Medicare expenses for duals and Medicaid expenses for duals, yes, you will be reporting the member months twice for this one person when you report those when you report that spending separately on those two lines, and that's fine. This is expected. Next slide. All right. Well, are there any questions right now about the clarification? Knowing that folks probably haven't had time to look through the draft manual and draft facts PDF. I just sort of rolled through them. But if you, after you review these revisions, if you have questions, please, you know our email, shoot us an email and we'll answer it and or also talk about it in the April TAG meeting. Okay, so on this slide, this is a heads up. We're compiling the data submitter list for September 2023. So please, payer staff, watch your inboxes. We will be notifying you of your reporter status in the coming weeks. Definitely for sure by April 30th, the absolute latest, but we're hoping to get that email out really soon. Yeah, the list of data reporters for 2023, like the previous 2 years, will also be posted publicly on the Cost Growth Target data submission webpage. Next slide. All right, so in the April TAG meeting, we're going to keep going on the 2023 data submission cycle. We'll review all 3 of these documents, the template, the manual, the submission facts, and we are aiming to publish the final versions of those documents no later than May 10th. And that link is a link to our data submission webpage. Next slide. All right, and that leads us to the end of the meeting. Our next meeting is April 26th, same time, same place. We'll review the draft documents relevant for the 2023 data submission work. And we will continue talking about the report and those public hearings, which are now split into two parts, one in May, one in September. And with that, that's the end of our meeting. Thanks, folks. Have a good rest of your Wednesday.
Thank you.
Bye.
Thank you.